Nausea. Just the word can make you feel a little queasy, right?
Oh, totally.
It's one of those universal, deeply unpleasant experiences,
Right.
whether it's just a mild rumble or, that debilitating, all-encompassing wave.
Hmm.
And the really complex part, figuring out why it's happening and, well, what to actually do about it.
Yeah, that's the challenge.
So today, we're diving deep into the intricate world of emetic pathways, which is really just a fancy way of saying how your body triggers that urge to vomit,
Right.
and the specialized toolbox of medications used to combat it. Our mission for this deep dive, which we've custom curated for you from a whole stack of insightful sources, is to help you understand the fascinating science behind effective, tailored treatment.
Because there's so much more to it.
Exactly. There's so much more to nausea than just feeling queasy.
It's true. While the feeling itself is, singular, its origins are definitely not. All the signals, regardless of where they start, they all converge on one crucial area in the brain, the vomiting center.
The vomiting center,
Yeah.
okay.
Think of it like the central command post for feeling awful.
So it's the ultimate target for all those distress signals, no matter where they come from. That's a powerful insight right there, right off the bat.
Exactly. And what's truly fascinating is that there are at least 5 main pathways leading to this vomiting center.
5.
Okay. Each one influenced by different things and involving specific neurotransmitters.
Yeah.
Those are the chemical messengers in our brain.
Got it.
So first we have the chemoreceptor trigger zone, often just called the CTZ.
CTZ, heard of that.
This zone is particularly sensitive to substances floating around in your blood. Things like chemotherapy drugs, opioids, or even biochemical changes like hypercalcemia.
Calcium, yeah.
And here, the key neurotransmitters are dopamine and serotonin.
Ah, dopamine and serotonin. So that explains why things like chemo or certain, strong painkillers can make you feel so incredibly sick. It's directly hitting this specific zone.
Precisely. It's a direct chemical trigger. Then there's the gastrointestinal tract itself.
Okay.
Right. Signals from issues like gastric stasis, where the stomach isn't emptying properly, or constipation, or even a bowel obstruction. They can send direct messages up to the vomiting center.
Wow.
And these are also modulated by, guess what? Dopamine and serotonin.
Them again. So gut issues are basically talking directly to the brain's I feel sick center.
It's a direct line. Yeah.
But what about when nausea feels like it's, all in your head, so to speak? Anxiety, maybe.
Well, that's when the cerebral cortex comes in. It plays a significant role.
Okay.
This pathway is responsible for things like anxiety-driven nausea or anticipatory nausea, that feeling you get before something you expect to make you sick.
Oh, I know that feeling. Like before you get a shot you really hate and your stomach's already churning.
Exactly that. So stress can literally make you feel sick through this specific pathway. And this one is largely driven by GABA.
GABA. Okay, different messenger there. What else?
Then there's the vestibular nucleus. This is where motion-induced nausea originates. Think motion sickness.
Ah, car sickness, seasickness.
Precisely. And this area is modulated by histamine and acetylcholine.
Histamine and acetylcholine, got it.
And finally, we have pressure receptors. These detect increased intracranial pressure, basically, pressure building up inside your skull.
Right.
And they can also send signals straight to the vomiting center. So the core insight here really is that nausea isn't just one problem. It's a symptom with multiple distinct biological roots.
Which means?
Which means a one-size-fits-all treatment just isn't going to be very effective, usually.
Wow, okay, that mapping is incredibly clear. And here's where it gets really interesting for treatment, I think. Knowing these specific pathways, it's like you said, having a powerful specialized toolbox. You wouldn't use a hammer to tighten a screw.
Yeah.
And now we can see you shouldn't use just any anti-nausea drug for any kind of nausea.
That's the ideal, yes.
Yeah.
When we connect each pathway to the specific types of medications that target it, the strategy becomes much clearer.
Lay it out for us.
Okay, so for the CTZ and the gastrointestinal tract, where we said dopamine and serotonin are the key players,
Yeah.
we use antidopaminergic drugs like haloperidol and metoclopramide, and antiserotonergics like ondansetron.
Ondansetron, Zofran, very common one. So for someone on chemo, targeting that CTZ with an anti-serotonergic like ondansetron makes a ton of sense.
Exactly. Perfect example. Now, for nausea, linked to the cerebral cortex, the anxiety-driven kind where GABA is involved.
Right.
GABA agonists, like benzodiazepines, can be effective because they help dial down those anxiety signals.
Okay, calming the brain to calm the stomach, essentially.
You could put it that way. And for the vestibular nucleus, Handling motion sickness?
That was histamine and acetylcholine.
Spot on. So antihistamines and anticholinergics are the go-to there.
Mhm.
Things like diphenhydramine Benadryl or hyoscine butyl bromide.
Right.
And lastly, for nausea triggered by those pressure receptors detecting intracranial pressure,
Yeah.
steroids, like dexamethasone, can help
Yeah.
because they work to reduce that pressure.
It's actually remarkable how understanding these pathways just transforms how we should think about treatment. This targeted approach, it really optimizes how well things work, and I imagine really changes the patient experience. You're picking the precise tool from that antiemetic toolbox.
That's the goal.
But like any powerful tool, it's not just about what works, right? It's also about what's right for you, the individual. We have to navigate the nuances, the contraindications, the side effects.
That's a critical point.
Yeah.
Absolutely critical. Understanding the limitations, the potential downsides of each medication is just as vital as knowing what it's supposed to do.
So where do we start? Maybe with the real common one, ondansetron.
Good place to start. So, ondansetron.
Yeah.
Very widely used. A major point to be aware of is that it's contraindicated, meaning you shouldn't use it in cases of QT prolongation, or if someone has a high risk of torsade de pointe. That's a specific type of irregular heart rhythm.
Okay, hold on. QT prolongation. Can you quickly break that down for us? What is that?
Sure. The QT interval on an EKG, it basically measures the electrical recharge time of your heart between beats.
Okay.
If it's prolonged, it means the heart muscle is taking too long to reset. And that delay can, unfortunately, predispose someone to dangerous, irregular heart rhythms, like torsade de pointe.
That definitely sounds concerning, especially for such a common drug.
It does, but here's the crucial nuance. While ondansetron might carry a relatively higher risk of torsade compared to some other antiemetics, the absolute risk of arrhythmia actually remains low.
Really? Even though it's used so much?
Yes. Despite its incredibly widespread use, there are relatively few reports of torsade actually happening. The key thing seems to be how it's given.
Ah.
The risk of torsade seems primarily related to rapid intravenous administration. We're talking pushing it in over just 1 or 2 minutes.
Okay, giving it too fast, RV.
Exactly. That can lead to very high levels in the blood very quickly. But this risk is minimized significantly by using the sublingual form, the one that dissolves under your tongue, or by giving the IV form as a slow infusion instead of a rapid push.
That makes a huge difference. What about other side effects?
Generally mild. You might see mild headache, maybe constipation, but again, given how much it's used, these aren't overwhelmingly frequent issues reported in the data. Rapid 5e administration can also sometimes cause bradycardia, a slow heart rate.
Okay. Any big drug interactions?
Well, obviously with other drugs that also prolong the QT interval, you want to be careful there. And with a drug called apomorphine, where it might cause loss of consciousness, there's also a theoretical risk of serotonin syndrome if used with other serotoninergic agents.
Serotonin syndrome, that's when you get too much serotonin activity in the brain. Can be serious, right?
That's right, potentially very serious. But with ondansetron, the risk seems negligible at standard doses, maybe even doubtful. And other interactions involving liver enzymes, CYP interactions, they're generally not clinically problematic.
Okay, so for ondansetron, watch the QT interval, avoid rapid IV pushes, but overall, the absolute risk of serious heart issues is low. It's more about how it's used.
Precisely. Now let's switch gears to metoclopramide. Reglan is a common brand name.
Okay.
This one has its own set of warnings. It's contraindicated in Parkinson's disease. Also, if someone's had a prior bad reaction to antipsychotics, things like dystonia, which is muscle spasms, or neuroleptic malignant syndrome, or tardive dyskinesia, the involuntary movement.
Like, those sound serious. Neuroleptic malignant syndrome.
NMS, yeah. It's a rare but potentially life-threatening reaction to antipsychotic-type drugs, characterized by high fever, muscle rigidity, confusion.
Okay, definitely something to avoid triggering. What else for metoclopramide?
Also contraindicated in seizure disorders, and, like ondansetron, in QT prolongation. Now, its role is interesting. It's actually a reasonably good prokinetic agent.
Meaning it helps move things through the gut.
Exactly. It helps with gastric emptying. But as a pure antiemetic for stopping nausea, it's relatively ineffective.
Really? That's surprising. I feel like it's used all the time for nausea.
It is, but here's the catch. Its main action is blocking D2 dopamine receptors. And that D2 antagonism is what causes those extrapyramidal side effects, the movement problems we mentioned.
Ah, the side effect is linked to its main action.
Right. And if you dose it low enough to try and avoid those movement side effects, well, it often stops working very well as an antiemetic. Kind of a trade-off.
Tricky.
Yeah.
Does it have any strengths then?
It does. Those prokinetic properties are definitely beneficial for conditions like gastroparesis. Also, it's non-sedating, which is a plus for many people. It doesn't have those anticholinergic or antihistamine effects that make you drowsy. And it might be useful and is considered relatively safe for nausea and vomiting in pregnancy.
Good to know. So ondansetron has potential cardiac flags, especially with IV use, while metoclopramide's big issue is the neurological movement side effects tied to how it works, really highlights the need for careful, personalized choices.
Exactly.
What about the phenothiazines? That sounds like a class of drugs.
It is phenothiazines. This includes drugs like chlorpromazine, prochlorperazine, compazine, and promethazine, phenergan.
Okay, heard of those too.
As a class, they share some contraindications. Again, QT prolongation is one. They can cause significant somnolence, drowsiness. There's a risk of respiratory suppression, slowed breathing. And similar to metoclopramide, because they also affect dopamine, there's a risk for extrapyramidal side effects.
So caution needed in patients with Parkinson's or a history of those movement issues, or Lewy body dementia.
Absolutely. Now, looking at them individually, chlorpromazine has very broad receptor activity. It hits a lot of targets. This makes it a powerful antipsychotic and quite sedating, which can be useful in some situations, like severe agitation. But that broad profile means, well, a broader side effect profile too, more risk of EPS and hypertension, low blood pressure.
Okay, what about prochlorperazine, compazine?
Prochlorperazine, compared to chlorpromazine, tends to be less sedating. It also has fewer anticholinergic side effects like dry mouth, constipation. But it might actually cause relatively more extrapyramidal side effects.
More movement issues. Interesting trade-off again.
Yeah, most often things like acute dystonia, those sudden muscle spasms, and akathisia, which is that awful inner restlessness feeling like you constantly have to move.
Right, akathisia, got it. Okay, one more common one maybe. Diphenhydramine? Benadryl, people use that for allergies, sleep, but also nausea sometimes.
Indeed. Diphenhydramine. Its main issue regarding side effects is its strong anticholinergic activity.
Anticholinergic. So, dry mouth, blurry vision.
Yes, and more seriously, it can be problematic in people with narrow-angle glaucoma. It could potentially trigger an acute attack. Also risky with bladder neck obstruction or significant prostatic hypertrophy, BPH, because they can worsen urinary retention.
Okay.
And a big one, especially in older adults or those who are already vulnerable, is a high risk of delirium confusion.
So, not necessarily benign just because it's over the counter.
Definitely not. So the key takeaway from digging into these nuances isn't just about, avoiding harm. It's really about optimizing effectiveness by meticulously matching the drug not just to the nausea, but to the patient's entire profile, their other conditions, other meds, their risks.
Yeah.
What's fascinating here, I think, is how crucial it is to consider not just the primary effect stopping the nausea, but the drug's full profile for that specific patient.
Absolutely. Wow, that was a lot of incredibly precise and important information to unpack. Let's just take a quick breath. If there's one single thing you want listeners to really grasp from all these drug-specific details, what would it be?
I'd say it's that each of these powerful tools in our antiemetic toolbox, they each have their specific rules of engagement, rules that really must be respected to ensure patient safety and effectiveness. It's not just about stopping the vomiting, it's about understanding the why behind the nausea, to pick the strategy that's both effective and, crucially, safe for that person.
That's a really powerful distinction, not just stopping it, but doing it safely and smartly based on the cause. Okay, so what does this all mean in practice when you're actually faced with someone feeling nauseous and you need to choose the best course of action? Where do we even begin applying all this great knowledge?
Well, it always starts with a thorough initial evaluation. Honestly, the history asking the right questions and a good physical examination are often the highest yield investigations.
More important than tests sometimes.
Often, yes. They can frequently point you straight to the cause without needing a battery of other studies. But of course, if the initial look is unrevealing, then yeah, we might consider other things. Labs looking at electrolytes like calcium, magnesium, liver function tests, maybe lipase for pancreatitis, or imaging and abdominal x-ray, maybe neuroimaging if you're worried about intracranial pressure, even specialized things like gastric ultrasonography. The goal always is to try and pinpoint the why.
Right. Find the pathway. And surprisingly, you mentioned the safest medical intervention. It wasn't even a pill.
That's right, sniffing isopropyl alcohol pads, like the little alcohol wipes.
Really?
Yeah, studies have actually shown it to be effective, and it's basically harmless. So it can be used as a co-intervention alongside other things, or just while you're waiting for other medications to arrive or kick in. It's a great, safe first step.
Good tip. Okay, now let's open that detailed toolbox we've been building and think about grabbing the right tool for specific scenarios, keeping those side effects in mind. For instance, if that QT prolongation we talked about is a really big concern for someone.
Good question. In that situation, options like olanzapine, phenothiazines, which is another serotonin antagonist but with less QT effect, diphenhydramine, meclizine, or even benzodiazepines would be considered safer choices from a cardiac rhythm perspective. It's also worth noting that while haloperidol or droperidol can increase the QT interval slightly, the increase is generally minimal at the doses we use for nausea.
Okay, that's a helpful distinction for haloperidol, droperidol. What about someone with Parkinson's disease, given those D2 blocker risks we hammered home?
Yeah, crucial point. For anyone with Parkinson's or a history of those extrapyramidal side effects, you absolutely want to avoid agents that block D2 dopamine receptors. So, no metoclopramide, no phenothiazines like prochlorperazine or chlorpromazine.
Makes sense. What if the nausea is clearly from a vestibular cause, like vertigo or bad motion sickness?
If it's related to the inner ear, the vestibular system, then your best bets are usually those anticholinergic or antihistamine agents we mentioned, like meclizine, diphenhydramine, hyoscine. Dopamine antagonists can be an alternative if those don't work or aren't tolerated, but they aren't first line.
Okay. And for, just say, common gastroenteritis, stomach bug.
For straightforward gastroenteritis, dopamine antagonists like metoclopramide or prochlorperazine or serotonin antagonists like ondansetron are typically used and effective.
What about gastroparesis, where the stomach just isn't emptying well?
There, metoclopramide is often considered first line because of its prokinetic effect despite the antiemetic limitation.
Right, helping the stomach move.
Exactly. If that's not enough or not tolerated, then haloperidol or droperidol or perhaps olanzapine might be considered.
And for migraine sufferers, sometimes nausea is a huge part of a migraine attack.
Absolutely. For migraine-associated nausea, the frontline agents often include metoclopramide, prochlorperazine, or chlorpromazine. Ondansetron might be helpful, but surprisingly, the data supporting its use specifically for migraine nausea is a bit lacking.
Interesting. What about opioid-induced nausea? Very common problem.
Yeah, very common. Here, serotonin antagonists like ondansetron or phenothiazines seem to be generally effective. Metoclopramide, however, often seems ineffective in this particular context.
Good to know. And post-operative nausea and vomiting, PONV, another big one.
Big one, yeah. For PONV, the toolbox is quite broad. Dopamine antagonists like droperidol, serotonin antagonists, antihistamines, neurotransmitter-1 antagonists, which are another class we didn't dive deep into, but are used especially in chemodexamethasone. Even benzodiazepines can all play a role. Interestingly, standard 10 milligram dose of metoclopramide seems pretty ineffective for PONV specifically.
Wow, lots of options there. What about during pregnancy? Safety is obviously paramount.
For pregnancy-induced nausea and vomiting, the agents generally considered safe include metoclopramide and certain antihistamines like doxylamine, which is actually combined with vitamin B6 in a common prescription, and diphenhydramine. And importantly, especially in severe cases like hyperemesis gravidarum, it's crucial to consider giving IV thiamine, vitamin B1, because there's a risk of Wernicke's encephalopathy.
That's a critical point about thiamine. Okay, we're nearly there. Chemo-induced nausea, often very severe.
Yes, CINV. Often requires combination therapy. The mainstays are serotonin antagonists, neurokinin-1 antagonists, dopamine antagonists, particularly butyrophenones like haloperidol or olanzapine, and sometimes benzodiazepines for anticipatory nausea. Things like antihistamines, metoclopramide, and prochlorperazine are generally considered less effective here.
So the big guns needed for chemo and radiation-induced.
Similar to chemo in some ways. Serotonin antagonists, dopamine antagonists, and dexamethasone are often effective for radiation-induced nausea.
That covers so many different scenarios. It really seems like understanding the cause, figuring out which pathway is likely involved, is the absolute key to choosing the right agent from the toolbox.
It absolutely is.
But what if the cause isn't clear? Or maybe it's a mix of things contributing.
That's a great question. Happens all the time. For multifactorial nausea, or when the etiology is just unknown, haloperidol has actually shown pretty broad efficacy in some studies.
Haloperidol again.
Yeah, performing as well as therapies, specifically guided by the presumed etiology. So it suggests it might be a reasonable broad-spectrum option when you're just not entirely sure which pathway is dominant.
Okay. And what if you try one drug, the right drug, based on the likely cause, and it just isn't enough?
Good point. If a single antiemetic isn't cutting it, the standard approach is often to add a second agent. But crucially, you ideally want to choose a second agent that targets a different receptor, a different pathway.
Attack it from multiple angles.
Exactly. Because it seems many causes of nausea probably involve several different receptors firing simultaneously. So blocking just one might not be sufficient. Which, this all raises an important question for all of us, really. How do we empower ourselves, whether we're clinicians or patients, to make these really informed decisions when every single situation is unique?
That's a great question. We've really journeyed today, haven't we? From understanding those fundamental pathways of nausea, those intricate signals leading to the vomiting center, all the way to exploring our specialized antiemetic toolbox and learning how we can select precise, tailored treatments. It really just underscores the immense value this kind of knowledge has in transforming patient care, taking it from maybe a bit of a guessing game towards a really targeted, compassionate strategy.
I agree. And I think what truly stands out from this deep dive, for me anyway, is how understanding these, microscopic pathways really elevates nausea treatment. It takes it from just a simple make you feel better goal to a precise, compassionate, and scientifically guided intervention that should be tailored as much as possible to your unique biological fingerprint.
Well said.
So maybe something for you, the listener, to consider is just that delicate balance required to precisely calm the storm of nausea, knowing that a deeper understanding of the why really does allow for a much more effective and kinder how.